Good afternoon. My name is Dr. Alia Goyle. I'm a GP and a primary care clinical leadership executive for Black Country Integrated Care Board in Health Inequalities and Ethnic Minority Health. I'm delighted to be your chair today to welcome you to the third health webinar from the South Asian Heritage Month team on the health impact of migration, which ties in with this year's theme of Journeys of Empire. We'll be exploring how migration journeys are still impacting on the health of refugees and asylum seekers today and how healthcare professionals can help. I'm honoured to welcome some colleagues who, like me, have a wide range of experiences supporting migrants and asylum seekers across different settings, roles and sectors to share their experiences and answer questions. We have 3 guest speakers today, followed by a question and answer session. Dr. Homa Kabiri is a former Afghan refugee and a reproductive medicine specialist. Dr. Aisha Malik is a clinical lead at Wythenshawe, Brooklands and Northenden Primary Care Network and is part of the Migrant Health team. And Dr. Hina J. Shahid is a regional primary care network advisor for social prescribing and health inequalities, Healthy London Partnership, and also worked with the Doctors of the World. Please feel free to tweet, tagging in at SAHM_UK. You can also tag in our speakers and use our official hashtags, hashtag South Asian Heritage Month, hashtag Journeys of Empire, and hashtag Our Stories Matter. So with that, I'd like to welcome our first guest, Dr. Homa Kabiri. Thank you, Homa. Would you like to introduce yourself?
Yeah, I'm Dr. Homa Kabiri. I'm from Afghanistan, and it's about 5 to 6 years that I'm in the UK. And at the moment, I'm a reproductive medicine specialist and working in one of the IVF clinics in the Leeds. I have came to UK as a refugee, and I have a background of being a refugee and asylum seeker. And at the same time, while I was preparing for my PLAB exams, I was working as a children's advisor with the Refugee Council and with the Home Office. This is why I think I have a lot of experience of being a refugee and working with refugees. And I'm happy to talk about my experience today and also give you some tips and, about how to look after refugees. Thank you. So in my presentation today, I'm talking about, I like to differentiate between some terminologies because they are using interchangeably, and sometimes people don't understand the difference between refugee, asylum seeker, and migrant. It's very important for us to know as health providers. And also, I will talk about my experience and also from my point of view, how to help refugees. There are 3 terminologies. One is asylum seeker. Asylum seeker means that someone has entered a country and they have applied for protection from the government. They have applied for, they have put their application for processing to be granted refugee status to the government, but their applications are still pending. A decision has not been made, and they have no right to work. They have no right to pass the test as a medical doctor. This is my experience. And they are being housed by the government, and they have a minimum possible financial support. So these are, I think, they're the most vulnerable group of people we should be looking after. And the other terminology is refugee. Refugee means when an asylum seeker is granted leave to the UK or any government country, and they have a status now. This is when we call them refugee, and the refugee status is usually for 5 years. And after 5 years, they can apply for indefinite leave to remain in the UK, but they're still a refugee. The difference between asylum seeker and refugee is that asylum seeker has no right to work, to do nothing, just wait for their decision, 1 year, 2 years, 10 years. But refugee has the right to work. They have all the rights to live in the UK, use the benefits, but they're not citizens, and they don't have right to vote. And the migrant can be used as an umbrella term for both asylum seeker and refugee, but mainly when I was working with the Refugee Council and Home Office, migrants are people who just come to work in this country or for training. These are migrants. For example, the doctors we have from Asian countries that they have came here for training and they stayed here, they are migrants, they're not refugee or asylum seekers. This is why we need to be careful with using these terms. We should look after everybody. This is our job as a doctor, but asylum seekers are the most vulnerable group of people, especially women and young girls from Asian countries, especially from my country, from Afghanistan. So I just intentionally brought the WHO definition of health, although this definition is quite outdated and they have changed it recently. But it's the definition which is still official. Health is a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. So in this definition, there's the word physical, mental, and social well-being is very important. Physical, and honestly, when I was working as a children's advisor with Refugee Council, I'm not worried about their physical health because they learn how to look after their health and physical health. They know how to buy paracetamol over the counter. They know how to use some like traditional remedies. But I'm quite worried about their mental health and social well-being because the way they are housed in the country, the way they are treated, it's really, really deteriorating their mental health and social well-being. So I have listed some factors which will deteriorate their social and mental health, but it's not a complete list, and the list is not exhaustive. It can go longer and longer. One of the main factors are a dominant culture of disbelief. When they come to this country, they tell their stories, especially to the officers of Home Office or to the social service workers, to anyone, and no one believes them. They just think that they are making up these stories, and this is why most of the decisions about their application is delayed and delayed and delayed. And this is very common, especially with children. The children migrants, no one believes their stories, but those stories are really true from my experience, and they're worse. They are just telling the tip of the iceberg. When they come here, they have poor access to information. They don't know how to get information, who to ask, because you can hardly see a person in this country. You are just dealing with computer, and then the computer, if you're not used to using computer, and if you're not used to these websites, these complicated websites and complicated softwares, you can't get information. And they're really, really ill-treated with the Home Office officers and the immigration solicitors. When I came here as a refugee, I wanted my immigration solicitor to be an Asian woman because I was thinking that Asian woman will understand me and help me, but unfortunately, sorry to say that, but they don't. Because a refugee or asylum seeker is like a milk cow to them, and they are happy for them to have a negative decision, because if they have a negative decision, they can appeal for them and they can get more money. So a refugee is a source of income for immigration solicitors, and most of the refugees have very, very bad experiences with them, and some of them are even traumatized, and they don't want to see that person again, things like this. And the same with the Home Office, they don't believe them and they treat them as a criminal. When they go for an application, they think that as if they have done a crime, and things like this. I don't want to talk about it. And also the decision about their application is extremely long, and because I was working with refugee children, and when I was children's advisor, I was going with them with their interviews. You could see that the decision was made on the day of interview, but they will never receive the decision until 6 months, till 6 years. And I know people who are waiting for their decision for 10 years, and they have they're not allowed to work. They have no access to lots of services, and they're suffering with extreme mental health, and their social well-being is really, really bad. And that prepares the ground for them being used as a slave, or modern slavery, or illegal work, and lots of other illegal things. Of course, they have financial issues because they're being paid £5 a day. That is the only money they get from the Home Office, just £5 a day for your food, for your medication, for your everything, for your clothes, for everything, £5. And they have poor access to mental health services. There are some mental health services like SOLAS, like mental health by NHS, but their waiting list is 1 year or 2 years or 3 years, and by the time they get their appointment, they're already so bad. And only in Leeds we have about 5 to 6 Afghan young boys being sectioned in the mental health hospital, mostly traumatized by their civil solicitors, by Home Office officers, and due to long waiting and being stateless. In general, all paperwork process in this country, maybe it seems normal now to me a little bit, but it's really, really bureaucratic and very complex, and it's very difficult for a refugee to understand them. Poor housing is a big issue. The housing is outsourced by the Home Office to another company called G4S, and the houses they give to refugees. I'm from Afghanistan. We are a poor country. Even in Afghanistan, in the poorest part of Afghanistan, we don't have that much dirty houses, that much like poor houses. I have never seen in any part of the world. They're completely covered. The walls are covered with black mold and really, really dirty. And okay, I don't want to talk a lot, but that is causing a lot of physical health for them, like pneumonia, lots of other infections, and in general, and that deteriorates their mental health. And one of the problems is that when a refugee comes to this country, because this is one of the richest first world country, their expectations high. They expect that they will be treated well, they will be housed well, but when they see that damages them more and more. And the other problem is that they're repeatedly being re-traumatized by retelling their experiences. Everybody comes to them and asks them to tell their story, even if they don't need it, if it's not relevant to them. For example, you have to tell your stories to the Home Office officers several times, to your solicitor, to the caseworker of solicitor, to the social worker, to the housing officer, to everybody. And every time you tell them that you're living that experience again. I'm sorry.
Hi, I'm sorry we've had to take a brief pause there. Homa, if you're okay to continue, that would be fine.
Yeah, I'm really sorry. Yeah, I will continue.
So we'll give you a couple more minutes. Yeah.
It's okay.
You could just yeah, and then you can have a break before the questions.
Yeah, I'm okay. I'm okay. I can continue. Yeah.
Okay. All right. I'll let you.
Yeah, I need my presentation back on the screen. Okay, so also the another thing is the age assessment. Age assessment. I have attended more than 100 age assessments, and if they're doubting a child's age, they do something called age assessment, which is one of the worst experiences someone can have. It's a full-day session. They just put a child in a corner, 5-6 social workers questions them as if they're criminal and trying to find a lie, and if they're telling a lie, then they will assess them over 20. And it is really, really, the age assessment is the worst phenomena happening in the process of asylum seeker and refugee application. Anyway, I'm really sorry for children who are going through that. And also lack of access to technology, I experienced before, explained that before, and restriction to work is one of the problems. I knew lots of people that they work illegally, and also they have been used as modern slaves for a long time. We met 2 children that they were down in London in an underground for 2 years, and they were working on them. They were working really hard, 24 hours without sleep, without proper food, and because they were not allowed to work, and they were just waiting for the decision. So my experience as a medical doctor, as a professional, when I came here, I first of all, I didn't know what's the asylum system, how to apply, and what to say, what to say to make them believe me. I didn't know that. I was quite honest. I was brief, short, but later on I realized that you need to go into much detail so that they believe you. And also the same, I also already explained, the solicitors are the worst experience of a refugee and asylum seeker. And the online information is not helpful at all. They're so vague. You can't find the right information. There are phone numbers. When you ring those phone numbers for hours and hours, there's no one to answer. And the machines answer until you to go to dial 2, dial 3, and you never get an answer anyway. There's another problem with health professional dishonesty. Unfortunately, I have to tell that. This is my experience. I'm not generalizing, I'm not stereotyping or commenting on anyone, but everybody has been quite dishonest with me. The health professionals who came before me and they had the experience, they were not telling the truth. They were not telling just what they have been through, and you just had to find yourself your way. No one was guiding you. It was another problem. And the GMC, the PLAB exams, the preparation for a PLAB, it's quite a money-making philosophy. The whole GMC and all Royal Colleges, I think they're just a money-making or business-oriented companies. They just care about money, nothing else. Because the price of the PLAB exam, the cost of courses, there are lots of commercialized courses. They're providing preparation classes for PLAB. They're all really expensive. When you come here an asylum seeker and you have just £5 a day, imagine how you can pay for that exams. And there are some companies like some institutions like Ragu, Reach, or BMA. They had some budgets to help refugees and asylum seekers to pass the exams. But the people who are dealing with money, when you write an email to them, the way they reply to you, I have examples. If someone wants, I can show. I have kept them. They're quite intimidating, and everybody's treating me like a criminal. This is the main part. And honestly, I have borrowed money from friends, but I avoided to take money from BMA, avoided to take money from those institutions, because the process of getting that money is quite complex and intimidating. And also, there are lots of information in this country. You can thousands of courses and trainings which can help you, but they're all very expensive. And I have a master's degree in medical education from Keele University in the UK. And I know what it costs for a course to make it, what it costs for the whole logistics of it. The cost of these courses and trainings are unjustifiable. They are too high. This is not right for nobody. Even if I'm a doctor now, I have a good salary. It is very expensive for me. I don't know why no one is looking at these things. And as I said, there's another problem that you can't find someone to sit with them face to face to give you a career advice, to tell you where to go, which skills you have got as a medical doctor. I was consultant obstetric and gynecology back home, and I was running a fertility clinic. Our clinic was like a satellite clinic with India. We were doing everything for patients, secondary care, and then we were sending them for IVF and assisted conception to India. So I had a lot of skills, but I didn't know how to use it, how to sell my skills, how to find a shortcut to immediately go to this field. Finally, I found it, but it was really difficult, and it took me a long time to get to this point. So this was my experience. I don't want to talk about it a lot because I will get emotional again. I don't want to waste your time. So just how can we help the refugees and asylum seekers? As I said, asylum seekers are the most vulnerable. Please, as soon as you see them, look after them. They are they need a lot of help. I think as soon as every asylum seeker or refugee is getting registration with the GPs, I think a GP should bring them for a long, not that 8-minute appointment, bring them for at least half an hour appointment and do a proper health check, physical, mental, and all sorts of checks to make sure that their needs are met. And there's another problem with interpreters. Interpreters, I appreciate that all health facilities use interpreters, but there's a problem with dialect. And this is from my experience in Refugee Council. All Afghan people dialect is Dari, although Dari and Farsi are the same language when they are written, but when they are spoken, they're completely different languages. And when doctors are booking an interpreter, if it is an Irani interpreter, they will not understand each other. I have seen that lots of asylum seeker cases were ruined. They're waiting for decision made longer and longer just because the Farsi interpreter interpreted just one word wrong. There was a case that there was one word, believe me, and that child was waiting for 3 years because of that one word which was interpreted wrong. It's the same in the health setting, so we need to be careful. And also the same with Pashto. In Afghanistan, we have two main languages, Dari and Pashto. With Pashto, they book some people with Urdu speaker. People appreciate, they understand Pashto, but Pashto and Urdu are different languages. Just keep that in mind, please. And whenever they come for book for an appointment, it's because of they need interpreter, and they might need interpreter. It's good to book them double appointments. And also the approach ideas, concern, expectation is not working for refugees, because in our countries we just go to the doctor, we tell to the doctor, and the doctor does whatever is needed. We don't have any idea. If they don't know the health system, how they have an idea what should be done? They don't know how to expect, what to expect. That formula is not working with refugees. Don't use them, please, for refugees. Wrapping it up. And about Afghan women. Infertility is a stigma. They really need to be referred to fertility special services as soon as possible. And hypothyroidism and anemia is quite common in Afghan women. And malnutrition and deficiency of all vitamins the same. Just the last bit to please all royal colleges, if they add some another page or another information for asylum seeker and refugee doctors to help them get through the process as quickly as possible, because nothing that doesn't exist anymore. That's it. Thank you.
Thank you so much, Homa, for your very moving talk. I hope that you'll be available for questions, and I hope that wasn't too difficult for you to share your story. And thanks again for that. I'd like to move on to our next speaker, if possible. It's Dr. Aisha Malik. If you could join, thank you. Please introduce yourself and start your presentation. Thank you.
Yeah, hi. My name's Dr. Aisha Malik. I'm a GP. Thanks, Homa, for your talk. There's so much in that, isn't there? And I can just really recognise some of your experiences. For the last 2 years up until recently, I was a clinical lead for an enhanced service for asylum seekers, so purely asylum seekers in temporary accommodation. And so in this presentation, I'm hoping to describe how we designed the service and how we developed resilience and sort of care in a very, very tough situation. I'm just going to check, how do I share my presentation, tech people? Do I just click on it? Oh, here we go. Right, so just a bit of a disclaimer on the presentation. There are a number of slides, but sometimes the narrative may not directly follow those things. So I'll just start with a little bit of storytelling, I guess, around how the project came about and how we went about it. So in early June 2020, our primary care network was approached by the CCG. So I'm based in Manchester, to deliver primary care services to 250 people due to be temporarily accommodated in a hotel. This is quite a recognized sort of pattern. We're getting influxes of asylum seekers through various let's call them conduits. They're classified as illegal migrants, although there's no such justification for anyone being called illegal. You can seek asylum until you feel safe. Pretty sure that's the World Health Organization definition. And there was sort of this sudden placement of people in our PCN, a sudden need for GP care, and we were also in the midst of a COVID pandemic. So we were still pretty much isolating at that point. There were lots of fear around outbreaks. So it was a very, very tough challenge. And at that point, there was a national moratorium on evictions. So if you recall, a couple of years ago, there was a lot of press, wasn't there, around how homeless people shouldn't be evicted. We need to like sort of house everyone. And this was the case for asylum seekers as well. Sort of there was a ban on evictions and suspension of cases, really, if you like, because of a fear of sort of spread of COVID. So it was quite unique and extraordinary circumstances at the time. So the preliminary work around the needs of the population was undertaken by a business development manager. So I think that the people were placed on sort of June the 6th, but there'd only been a couple of days to prepare. Now, you know, some of this may be common knowledge to everyone, but it might just be worth sort of going through that. You know, there are common health challenges of refugees and asylum seekers. As Homa mentioned, it's not just about the physical. But what we do remember, what we do know is that chronic conditions, they are very poorly controlled. So hypertension, diabetes, epilepsy, you know, injuries, you know, chronic medication, and it's all to do with a lack of access, really. A lot of our patients have had very checkered, very fragmented journeys across the world, really, through refugee camps. And, you know, by the time they come to us, you know, something as, you know, seemingly benign as hypothyroidism is so poorly controlled that it's rippling into other areas of health, including mental health. I know there's another talk around mental health, but what I will say is that, you know, the volume of PTSD that we saw coming through the service, as GPs, we can screen for PTSD. Our health system is extremely poor at responding to PTSD, or as we know, there's a crisis in terms of mental health access. If you sort of quadruple that for asylum seekers, you know, we just don't have a system that can cope with the amount of PTSD that we're seeing. So what I found was using standardized screening tools that had been used in veterans, it just helped to anchor some fact into the record that actually, you know, this patient doesn't just have depression, they've got PTSD, they've got very, very traumatic, very recent experiences. We need to be sensitive to that. Recording those things, what we found also helps legal cases. So again, with reference to what Homa said, there's such a huge part of, there's such a huge interaction, if you like, between medical and legal. Like what you put on that record can really help somebody. Just moving on, maternity care. If you look at sort of statistics, you know, maternity mortality and morbidity is highest in ethnic groups. Statistically, I think in Black women, you know, that's what's recorded. But what I would say is if you've got a population that are 70% below the poverty line, have not had access to pregnancy care at all, you can imagine the risk. And we did have pregnant women housed in that hotel right from the word go. So we really were sitting on a lot of risk, and it was really, really important to make sure that there was holistic support there. And then untreated communicable disease. So on the sort of government website, you can go and look at kind of migrant health screening and what it should involve. And it was interesting at that point in the middle of the COVID pandemic, a lot of communicable disease sort of screening had been suspended because of COVID, because all the resource was there. And one of the areas that was definitely suspended was TB screening, but we actually decided to screen because what we found were people were housed, they were isolated in this sort of a hotel. There were 250 people, so we thought COVID's not just an issue here, TB is as well. So there was a lot to consider, and obviously Homa just, you know, described language and interpretation needs. What I think the one thing that I would add is, you know, I might be fluent in Urdu, I'm not fluent in Pashto, Farsi, and we also had Arabic speakers, Kurdish, Somali, and many others. It takes a lot of skill as a GP to provide trauma-informed care, to be empathic with a telephone interpreter that may actually not have the skill to capture the nuance of trauma, mental health, and all the other issues that were coming in through the door. So it was a massive, massive challenge. I'm just gonna move on. Alia, I'm aware we're time restricted, so if I do see your face pop up, I will try to prioritize slides, so do just let me know. What have I got here? A bit of repetition here. We've talked about long-term condition management. I think there were sort of other culture-specific things. So I know that some of the focus of the talks has been on the sort of Afghan refugee crisis. What I will say is there's such a massive displacement of people, due to war, due to conflict. We've seen asylum seekers from Syria, Yemen, right across the Arab Peninsula, also Ethiopia and Eritrea, and hopefully there should be a slide later specifically on safeguarding. One of the things that we also had to screen for was, issues that were specific to female health, including the risk of FGM. Looking after asylum seekers requires a very comprehensive skill set, I found. But what one of my mentors said to me, so I don't know if anyone's done any academic reading, but certainly a name you'll find is one of kind of the Dr. Rebecca Farrington. She has a role at Wonka as well, and she just said, you really have to have the heart for this work. You really have to be, it's not just about being a good GP and being a good generalist. It's actually really having the heart for this work and being able to recognize things in its totality, and actually having the gut and the mental toughness to tackle some really tricky issues that aren't just somebody else's problem. Because as Homa described, asylum seekers are so excruciatingly vulnerable. They literally don't fall under anybody's remit. They just fall through the gaps. So it was a very charged atmosphere, I think when we started, and it was really important to lead with not just this sort of compendium of issues that I've described, as just coming at it with a bit of heart, really, and with a trauma-informed approach. I'm not sure what my next slide says. Yeah, so GP care alone is not enough. Obviously, I won't go into the social prescribing side because I'm aware that there's a presentation following mine, but there is very much here consideration of, well, this is a GP appointment, but my patient needs a lot more. And what was really great in our primary care network at the time was that there was a very coordinated effort to linking through to community services, district nursing, maternity services, actually seeing whether people could get access to legal support. At that time, like, offices were just closed. It was a bit mad, really. Legal services that are so integral to well-being and access, like all the legal offices were closed. So we really had to sort of hammer the CCG and the locality and say, look, there needs to be some sort of access. We know everyone's isolating and everyone's working from home, but our patients don't even have mobile phones. So how can you help? There were other sort of practical considerations as well. 250 patients, how the GP practice is going to register them. There were lots and lots of other considerations in terms of setting up the service itself. Because we were in the midst of a pandemic, we had to have much longer appointment times to allow for clean downs of rooms, to allow for PPE, all of the safety things that we needed for ourselves, for clinicians as well. I'm just going to skip on from that slide. Oh, and also dedicated pharmacy support. We found it was difficult to. It was very interesting. Patients had this expectation that if we're a health service, we're also a dispensary and a pharmacist. So even the logistics of working out pharmacy delivery during the pandemic for the patients and residents there was it was another piece of work in itself. I just want to have a word about safeguarding as well at the moment. I think safeguarding, if I'd had time, I would have put, a formal definition, but assuming this is going out to GPs, everybody knows what safeguarding is. It's difficult to describe just how extreme the vulnerability is of asylum seekers. And Dr. Homa touched on this as well. But what we found in initial accommodation Patients don't even get that £5 a day because it's considered, because they have a roof over their heads and because they're fed from sort of canteen food, that's your expenses paid for. So what you have is an extreme level of deprivation. It's actually 70% below the poverty line. That is already predisposing to neglect and all the things that we see in terms of extreme vulnerability that need safeguarding. Now, I remember walking in there as clinical lead and thinking, well, if you were going to look at formal definitions of safeguarding, all 250 of these cases are safeguarding cases because there's extreme vulnerability here. One of the challenges that we have is that the state, our country, does not fund local authorities any differently or give them any additional funding for care of asylum seekers. And what I discovered from colleagues was that then puts safeguarding cases for asylum seekers at the bottom of the pile. And so what we really had to do was really hammer the importance of our patients not being neglected. And that involves relationship building, finding the right people in the system that will recognize that these patients are vulnerable and are driven by a sense of purpose rather than what the manager is telling them should be on their caseload. Cases that we saw within the hotel included domestic violence. There was lots of nuance around this. What I would often lead with our domestic violence cases was sort of a very critical eye, if you like, of, well, if you had just fled your country and you'd experienced trauma and war, and you are living with your wife and your 3 children in a single hotel room, and you cannot leave that room, and you have no money, and you can't find a job, and nobody's processing your application, then that is a pressure cooker for neglect or assault or somebody lashing out. And without passing any moral judgment, I would often put myself in that position and just think, how far can you push a human being? What are the predisposing factors here, and how can we actually do safeguarding, which is do some early intervention, get people early help. It was extremely difficult, and it relied on a really good team that I did manage to put together. Child abuse or neglect, we did see elderly neglect, honor-based violence as well, and what we found was that constant negotiation and working with partners was essential. Having a trauma-informed approach, a trauma-based approach to GP consultations would actually help as well to dissipate a lot of the tensions. What I would say is, just if you start with a recognition that if you've got an asylum seeker, they're going to fall against the gap. You're up against the system in terms of getting even a basic level of care in place. That's sort of probably the baseline, really. And get help. Find good people in the system to help you with these cases, because they do exist, but you have to be persistent. Support for staff. So I want to talk about moral injury here. So it is very difficult as a caregiver, as someone that stepped into medicine, as I'm sure we all did once, many moons ago, in order to actually make a difference before we became bogged down and disillusioned by the system that we're in, especially if you look at the current state of general practice. But I wanted to describe the very real phenomenon of moral injury, and I was lucky to have mentors that were very experienced in asylum care. And moral injury, I'm just going to go through a definition here, and the BMA have done a report on it. There's a link there. I would encourage anyone to have a look at this. But it's described as injury that can occur when someone engages in, fails to prevent, or witnesses acts that conflict with their values or beliefs, and when they experience betrayal by trusted others, especially when this is perceived as avoidable or they are powerless to change it. What I will say is, working with asylum seekers, it is so obvious how hostile our environment is, how hostile our government and our health system is to asylum seekers, that sometimes you go home and you think, I can't do what's needed here. I can't get a social worker here. This is going to take me like 10 days. What's going to happen then? And there's all this doubt, and there isn't really a support mechanism there. So recognizing that this can impact you is really, really important. Self-care, what I always said to my staff was, make your back strong. What do you need to do for you to build up your own strength? I'm not going to use the word resilience because I don't like that very much. But I just want to put that there, like if you're working with patients, just consider moral injury. And then what I just also wanted to add, and I might actually just end there, is that this work is deeply, deeply transformative. It does change you as a person. You do see the world in a different way. And sometimes that can be very difficult to communicate to commissioners, service managers, people that might be threatening your funding. So what I would say is, find other people in the system. There are evidence bases that exist for serving these patients. There's deep entrenched racism within the NHS. There's an evidence base for this. Stack your arguments. All of that will help if you're trying to build a service and then trying to continue it. And I'm actually in that position at the moment where it's changing hands, and I'm sort of having to fight a lot of battles. So you need to be aware a little bit of the political landscape. Don't assume that the team around you will always be there. It's constantly changing. And, you know, sadly, what I would probably say is that it just seems to be getting more hostile than ever. But if there is anybody watching this that is leading a service or involved or wanting to make a change, please do reach out. And then hopefully I can help. So racism, I think I just want to link this through to the moral injury aspect. So the slide before that was supervision. Try and find a mentor if you can. Reach out to me if you're trying to look for somebody. It can really help even with unpacking cases. But I think with racism, it's really important to sort of develop an approach, even if it's just personally for yourself. And there are evidence bases for approaches as well. And again, please reach out, because I tend to use a few key arguments. The reason I also say this is because it can help you when you're going home with that burden, that moral burden of like, I'm really trying here and nobody wants to help. How can I articulate something as squeamish as racism? It's really helpful to just remember a few key things. And so one thing I will say is that recognize that racism is endemic. This is known. So if people are saying, I'm not racist, or this isn't racist, just say, well, actually racism is endemic, it's institutional, and a lot of it is unconscious as well. So you saying that there isn't racism is a non-argument really, and you can state that very politely. The second thing is, understand that if a member of staff or a patient comes to you and says, look, something is racist, I feel this is racist, or I've experienced racism, and that might be as simple as a pharmacy, an example we had as a pharmacy consistently trying to charge asylum seekers for prescriptions. What I would say is recognize that somebody telling you something racist is a disclosure. It's not a complaint. It's a disclosure, and it should be treated as such. So don't say that's not racist. You need to really listen to the person. Okay. And then what I would also say is if you do think that there is institutional racism at play, this is tough stuff. I just took on an entire radiology department that was refusing to screen my patients, and I've actually got somewhere, and I did that as a lone wolf. And I'm happy to share that, you know, another time, or with anyone that chooses to learn from it. But if there's one thing that I will say is that the McPherson report, you know, the Stephen Lawrence case, if you look at the McPherson report and the revisions of it, it says that anybody can raise racism. You don't have to have had the direct experience. You can have witnessed it, or you can be an ally. And then if you are raising institutional racism, that organization has a duty to investigate whether institutional racism is at play, whether it is or not. And you can quote that, and it does move the needle, because they have to listen to you. They can't say, no, it's not racism. They have to say, okay, what's going on here? And that can provide a lot of relief. So if anyone, again, please do reach out if you need anything. I'm not a formal race advisor. I don't think there is such a thing at the moment, but this stuff does work. I am going to stop there, but I hope that's been helpful.
Thank you so much, Aisha. Again, there's just so much to unpick, and I feel so bad that we have very limited time because we could certainly go on. I'm going to move to our final speaker, but I think it's really important to kind of know how people can contact you. So we'll hold that thought and we'll come back to that at the end. So I'd like to finally introduce our final speaker, Dr. Hina J. Shahid. So please join us, and then you can introduce yourself and get started.
Sure. Thanks so much, Alia, and thank you for having me here. And it's been just so, I've learned so much just listening to Homa and Aisha about their work and their experience. So I'm Hina, I'm a GP in inner city London. I've also got a background in public health and have spent about 10 years or so working in international humanitarian projects, but also in community groups and charities in the UK as well. I've got some slides, if somebody could just kindly put them up for me, thank you. And my other role that I have is with NHS England as one of their regional advisors on social prescribing and personalised care. And one of the things that I've really noticed throughout all the different kind of dimensions of work that I've done is our focus as healthcare professionals on where health is created and where health risks are formed is wrong. What we know is that health is created in communities, and there seems to be this huge gap between NHS and healthcare services and communities. And social prescribing, personalised care is one way in which we can bridge this gap. Also reflecting on what Homa and Aisha were saying earlier, the work that I've done with both refugees and asylum seekers, there definitely is a higher need amongst asylum seekers and more risks and vulnerabilities that that particular group experiences. And for the purpose of this presentation, I'm just going to be speaking about migrant health in general. And you can refer back to Homa's slides earlier around the different definitions. So just move the slides along. So firstly, what is personalised care? So personalised care is part of the NHS long-term plan, and it means that people have choice and control over the way that their care is planned and delivered, and it's based on what matters to them and their individual strengths and needs. So it sees an individual as a biopsychosocial whole, as a person and not a disease or collection of conditions. And it's really a means of enabling GPs, nurses, and other healthcare professionals to refer to people to a range of local non-clinical services, which includes connecting people to community groups and statutory services, so making sure that patients are supported in the right place, by the right person at the right time. And in particular with migrant patients, where their needs are so complex, where there are so many different layers of vulnerability, sometimes as a GP it can feel quite overwhelming to be able to address all of those. And actually we don't really need to do that. We have really skilled professionals in our personalised care team who are able to do this and support us and support patients. So these are the 6 key principles of personalised care, with what matters to me at the centre of it all. So it's shared decision making, enabling choice, health coaching and supported self-management, social prescribing, personalised care and support planning, personal health budgets, and integrated personal budgets. And this is an example of what a simple social prescribing pathway can look like. And obviously, it will look different in different areas, because the whole point is that it's responsive to local needs and priorities. So you may have an individual patient who presents with complex needs, goes to their GP, and their GP then refers on to a social prescribing link worker, who is somebody that is well connected with the community, who understands the resources and assets that are present within the community, who's able to assess the needs of that patient and then refer onwards to appropriate services. And I'll be speaking about some specific services that have been commissioned and developed across the UK for refugee and migrant patients. And some of the outcomes that we see, the positive outcomes, are improved health and well-being and employment opportunities. And I'll go through this in a bit more detail in a few minutes. So a quick note about some of the roles. So many people will be familiar with social prescribing link workers. So these are professionals that address the wider issues that impact people's health and well-being, so linking with those community resources that I've mentioned already. They are able to take time with patients to see them over several sessions to identify what matters to them and connect them with a range of practical, emotional and social support, and also various activities. And very importantly, they act as a bridge between primary care and the community by identifying and nurturing community assets, as I've mentioned, and can support people with a whole range of issues ranging from loneliness to complex social needs, mental health needs, and multiple long-term conditions, which we've heard already, disproportionately impact our migrant patients. And in response to growing challenges that we're seeing in terms of demand for GPs, but also the complexity that patients are presenting with, there have been 2 other roles in the personalised care team that have been rolled out through the additional roles reimbursement scheme for NHS England that are available for PCNs to directly employ or host, and these include health and wellbeing coaches and care coordinators. And many colleagues I find are not particularly familiar with these 2 roles as they are with link workers. So health and wellbeing coaches essentially work with patients to increase behavior activation and motivation. So maybe involved with supporting with goal setting and behavior change, and can be very useful to support patients who have multiple physical and health and mental health needs, or one or more long-term conditions, but also those that are at risk of developing a long-term condition, so really intervening early on. And then you've got care coordinators who work with patients in supporting access to healthcare, navigating the complex healthcare system that we've heard Homa and Aisha already describe. They can provide coordination and access to other appropriate services and support, and serve a very important allyship and advocacy role as well through the continuity of care that they provide to patients and cohorts. And they can be very useful to support patients who may be struggling with multiple appointments, with chronic conditions, also specific groups, to frail and elderly, and working with care homes. But it may be that in your PCN, where you do have a large number of refugee and migrant patients, that you can have care coordinators that are specifically used to support that particular cohort. What we also know, actually, just to say, is that 1 in 5 GP appointments are for wider social needs, and these are likely to be much higher for patients who come from migrant backgrounds, who are recently resettled. And so social prescribing personalised care really does have a very important role to make sure that patients are adequately supported, and that it doesn't just all fall onto GPs. So this has already been covered, so I'm not going to dwell too much on the health risks and vulnerabilities because they've already been described. But I really want to focus on some of the social vulnerabilities that that migrant patients are likely to experience. And again, some of these have been mentioned, but really looking at the social determinants of health, such as housing and homelessness, employment, financial status, social support and isolation, which these patients are more likely to experience. And what we know about social determinants of health is that they are the major drivers of health outcomes and health inequalities. And it's not medication or direct access to healthcare services. As I've mentioned right at the beginning, health is mainly created in communities. And so it's really important to make sure that we're addressing these social determinants of health that reinforce health inequalities and poor health outcomes. Also, migrant patients experience barriers with language and communication, as we've heard, and exploitation, so trafficking, modern day slavery, violence, and safeguarding risks as well. And then they face barriers with healthcare in terms of access and experience. So knowing how to access the healthcare services, issues with registration, providing ID and address, which we know is absolutely not required, but yet GPs are still requesting these from patients. Also, they may be scared or fearful of accessing healthcare because they are worried about their immigration status being checked or being deported, or seeing healthcare professionals as being part of the establishment. They may have communication and information barriers, physical barriers as well, in particular with frequent relocation, which we do find whole families actually being subjected to, moving across the country frequently. And so they never really develop that ongoing continuity of care with any healthcare service provider, and the huge stigma, especially around mental health. And when these patients do then access healthcare, they're more likely to have negative experiences through bias, prejudice, discrimination, feeling that they're not being heard to, listened to, or believed. They may have a previous history of medical torture in their home country, And so this all creates a lot of mistrust and suspicion. So how can social prescribing support refugee and migrant populations? So there was a really large literature review that was carried out, a systematic review that was published last year, and you can have a look at this yourself, which really mapped out the range of prescribed activities that are being made available for refugee patients and groups. And you can see here a whole range of activities, from legal welfare support through to financial and employment support, encouraging community participation and social isolation. Language and cultural support that we heard are huge issues, training and education, housing support for mothers and children, and supporting additional groups with additional vulnerabilities, so safeguarding domestic violence, addiction, information and coaching, and staying healthy and well, a range of practical support for everyday, for day-to-day livings, food, help around the house, and physical activities and sports, arts, gardening, faith-based activities as well. So all of these needs that we know exist in these communities and in these patients can be addressed through social prescribing. And in the paper, they also list some of the outcomes and some of the evidence that they've collected for these. So I encourage you to have a look at that paper, and I put the link at the end of the slides as well. So how can we improve migrant health through personalised care and social prescribing? So there is a very useful guide that you can have a look at on migrant health and social prescribing. And the guide really divides up kind of support for referrers, for link workers, for commissioners and researchers. So specifically for referrers, which as healthcare providers we are, it's important to have an awareness that migrants require a greater range of prescribed interventions and activities than the general population. So really thinking about, well, do you have an understanding of what these of what their needs are and how they can be adequately addressed through social prescribing, and thinking about innovative ways and service as well. Recording social prescribing referrals and activities in electronic health records, which isn't done very well, unfortunately, and thinking about how you support your personalised care workforce through supervision and opportunities for further training and development, remembering that actually this workforce is dealing with a very vulnerable and complex, so dealing with patients with very vulnerable and complex needs, and so they need additional support and training. And as a supervisor, as a commissioner, how are you enabling that? And these are some recommendations for link workers as well. So what can social prescribing do and personalised care do for newly arrived migrants, and how can we use this workforce effectively? So they can be helpful in proactive outreach, so really identifying where unmet needs lie in our communities, the communities in which these patients come from. They can support migrant patients to access primary care services, registration, navigation, self-management resources. They can really help with relationship building, engagement, encouraging utilisation of healthcare services. We know that there are huge areas, that they are underutilised. They can encourage confidence, control, and empowerment. Develop outreach partnerships to really meet the complex health and social needs and social and community connectivity in more holistic and joined up ways. Because they spend more time with patients than we may do as GPs, they may be the first ones to really identify red flags like abuse, exploitation, trafficking, modern day slavery, and then be able to advocate for them to challenge the system with downstream effects. And I'd also encourage you to think about how you can develop these as a one-team approach, so where social prescribing link workers, health and wellbeing coaches, and care coordinators are working together to holistically address the needs of migrant patients. And just something about culturally responsive social prescribing. So there is a module that I helped develop with colleagues with NHS England and Health Education England on culturally responsive social prescribing. So I'd encourage you to have a look at that as well. And just a few key points to think about when we are looking at social prescribing for patients with diverse cultural needs. So the first is really thinking about, having a human rights-based approach and and understanding the ethical principles that govern our interaction with patients who are very vulnerable, and in this case, migrants, refugee and asylum seeker patients. How do we show up with these values in our interactions? Do we have an understanding of what the social determinants of health are that impact these patients, and what services, what community groups are available to support them, and where are the gaps, and what can we do to address those gaps? And in particular, if you have a commissioning role, I'd really encourage you to really think about this and supporting commissioning services like what the service that Aisha runs for asylum seekers, and really thinking about how that can be supported. Aisha also mentioned Rebecca Farrington. So Rebecca and I have created a framework for cultural humility and safety. So this concept of cultural iceberg exists where we know, and again, this is in the e-learning module. So the majority of what we think we understand about people's culture is actually just the tip of the iceberg. It's those things that are easy to see, but actually the majority of people's culture is hidden. And how do we access these hidden dimensions is through cultural humility, where we and through that creating a safe environment where we can have these conversations, really understand what patients' needs are and what matters to them, and be able to address them holistically. Another key concept to understand is intersectionality. So we often talk about migrants and refugees and asylum seekers. We may talk about, Afghani asylum seekers, but actually it's important to understand that these are not homogenous groups, and even at an individual level, each person is different and embodies multiple axes of social identities which overlap and may increase their risk and vulnerability in very different ways. So how do we understand at an individual level how risks overlap, and how can we then address those through a tailored, personalized approach? Trauma-informed practice, and I'm really glad that Aisha mentioned this. We know that patients who have had these really difficult migration journeys, experience trauma and conflict at home, come when they arrive to the UK, come with really complex needs, and trauma underpins a lot of this, and yet we're so poorly trained in recognizing and responding to trauma. And trauma-informed practice doesn't mean that we become trauma therapists. It means, do we realize how widespread trauma and its impacts are? Do we recognize what some of the signs and symptoms are? How do we respond, and how do we resist re-traumatization? And especially if you are working with patients from migrant refugee backgrounds, it's really important to familiarize yourself with the key principles of trauma-informed practice and approach. The 6 key principles are listed here. Doctors of the World has also produced a really helpful guide for social prescribing link workers that you can have a look at, and really focuses on building trust and looking at the importance of language and creating safety. And so a few other considerations are, thinking about cultural and religious sensitivities, especially around sexual, reproductive, and mental health. That's already been mentioned for both link workers and also as a healthcare provider, and as a healthcare provider who may be supervising link workers as well. Knowing procedures around how to communicate information around confidentiality, data sharing, and entitlements to care, which are repeated concerns that come up with migrant patients. Knowing the protocols for raising concerns and developing protocols to identify at-risk groups as well. And then finally, reflecting on our own personal values and behaviours and how they show up when we are interacting with patients from very vulnerable and diverse backgrounds. So, thinking about how self-aware we are, what our personal values are, what are we doing to address some of the personal biases that we may be harbouring? How do we bring in cultural humility and curiosity in our interactions? And are we engaging in reflective practice to improve and better the way that we provide care for these patients? So a few key points to take away around social prescribing personalised care and looking after migrant patients. Recognising that they experience multiple complex physical, psychological, and social challenges. Thinking about social prescribing as an important intervention to support these vulnerable populations by addressing the social determinants of health and acting as a bridge between primary care and communities, but also serving as important advocacy and community recovery tools. Along with link workers, looking at how care coordinators and health and wellbeing coaches in primary care can also support patients with these complex needs, and also in terms of healthcare access and navigation and multiple chronic physical and mental health conditions. There are tools and resources available for you to be able to use to support those patients. And when you are thinking about personalised care and social prescribing and delivering these for your patients, how are they culturally responsive, safe, and driven by ethical values and principles? So just a few key points for you to think about, and I've got all the references and resources here as well for you to look up in your own time. Happy to be contacted as well if you have any further questions following this. Thank you.
Thank you so much, Hina. Thank you for sharing all your expertise with us. An absolute wealth of experience with resources which people can look back on through the YouTube links and share. I'd like to thank you all for your time today. I've learned so much, and it's just, I thought at the beginning that an hour was just not enough for something. I think each of you individually could have had much more than that. So, you know, let me apologize if you felt rushed in any way. There's just so much that we can share from you. There are a few comments more than questions, I think, really around ensuring that people who come to our shores have a sense of purpose and self-worth, and the importance of an overall kind of holistic care, signposting to community groups, because culture and context is important. And I do think that the way we treat refugees, asylum seekers and migrants says a lot about who we are, not just about you know, them and their backgrounds. And we really need to make sure that we're not re-traumatizing. There aren't any further comments and questions, and I'm very aware that we've overrun. Before I let you go, would you be able to just let us know how we can, how people who may be listening would be able to contact you? So Hina, how would you like best to be contacted?
Happy to be emailed. So my email address is hina.shahid, shahid1 @nhs.net.
Thank you so much. Homa, would you be able to be contacted?
Yeah, they can contact me by my email address. It is Homa, my name, HOMA.KAB@gmail.com.
Thank you so much. And Aisha, you also mentioned that you were happy to be contacted. What's your preferred method? Oh, sorry, you're on mute.
Yeah, no, it's okay. Yeah, no, so also email, probably my Gmail account is best. So Dr. DOCTOR Aisha Malik, AISHAMALIK @gmail.com. Yeah, just happy to be contacted via email.
Thank you so much again. And if anyone has misheard any of those email addresses, then you feel free to Twitter message me, DM. My Twitter is at the bottom @Alia_UK, and my DMs are open. So with that, I'd like to thank you all again for your time. And I'd like to reintroduce the next section. Thank you so much.
Thank you.
Thank you. Thank you everyone for joining us today. I'd like to end with a reminder that the 15th of August will mark 1 year since the fall of the Taliban. And in light of this year's theme of Journeys of Empire, we'd like to finish by sharing a visual project called We Are Here Because You Were There, Afghan Interpreters in the UK, created by the Sulha Alliance. Through photography from Andy Barnum and interviews with newly resettled Afghan former interpreters, it gives insights into their stories in Afghanistan and early experiences in the UK. Some of the images and the phrases may upset. Thank you.